Well, thank you very much. It's been really interesting, and I'm ever so grateful for the invitation to be here. It's really nice to be spending not just today, but of course, the rest of the week and a little bit of next week as well. So I'm really looking forward to that. You see all these wonderful titles and awards and all these important things that are on my name here. Importantly, there are two things there. I'm the chair of the NHS Institute for Innovation and Improvement, which has a budget of £58 million a year. And 3/4 of my workforce who innovate, improve and change services and have significant grant are nurses by profession, because they are really marvellous change agents. They understand that stuff. So they can bring the sciences together down to bear on service improvement and change in a way that others find quite difficult, I think, sometimes. So David gave a really good account of business here and how the research landscape is shaping up. Don't get depressed, okay? There's lots of money in the system. You just have to know what it is you're asking for. And okay, you may not get it from those medical research councils, as we find it very difficult to do in the United Kingdom, but there's other stuff elsewhere, like this, for example. Secondly, this Foundation of Nursing Studies on a much more modest scale gives awards to nurses who run wards or units up to about £7,000 to change practice, to innovate, to introduce some kind of difference into the way they deliver care. Very modest, but is quite life-changing for some of those people who have never been able to bring change to those clinical environments. So it's really quite important that we think about a broader landscape when you think about that investment. But just to show you what a seamless presentation of an afternoon this is, I'm going to refer to McKeown a little, because we've had some similar experiences in the UK and some of the things which have followed on from that. So I will deal with that as well. Okay, so I'm going to talk a bit about indicators and opportunities. I'm going to talk a little bit about the need for excellence and centres of top-ranked activity, because we're going through yet another research assessment exercise in the United Kingdom, but it's got an interesting tweak this time. Really quite interesting, which I'll talk about. What do we talk about when we talk about research in the health sector? Because we're starting to have different kinds of debates now about what is research then? What is improvement? What is quality improvement? What do we talk about when we talk about that research landscape? Why would you want to be one? Why on earth would you want to be a researcher, is the question. And there are several answers to that. And people of my generation certainly have plotted a very complicated pathway to become accomplished researchers. And we're trying to change that. And David referred to that at the outset, to invest in the careers of research and research scientists. A little bit about how you get a reputation and you keep it. My sense is, having spent only a morning here, really, is that this is a university in search of an identity in this area. It's not that you don't have it and you're not good at it. I don't think you've declared it sufficiently well, perhaps. And one sense is that McKeown gives you that opportunity to do that. So I would encourage you to be quite upfront about what you think you're good at and where you may sit in these new plans, these new opportunities. And then finally, just to talk a little about new things which are going on, certainly in some parts of the UK and elsewhere, about evidence research-based education in undergraduate and postgraduate programs. So just a little bit about that. So I think, when you think about indicators and opportunities, when you think about strategic thinking, those things which David has articulated so very well, this is an interesting place to be now. You might not think you can lay a hand on the dollars, but the landscape is being shaped in such a way that you might bring other monies to that table, I think. So it sounds unfair, and nurses and other allied health professionals get pushed to one side, but that's the way it is. It's the same for us too. But you have to think about it in a broader perspective, I think. So there's a good impetus here to think about that. And there's an invitation, I think, to stake a claim or somehow participate in that emerging landscape. Excuse me while I drink tea. It's good for the throat, but I'm also very English, so you'll let me do that. I think in your ambitions you have to be quite modest. And by that I mean you'll be really good at some few things. You won't be good at everything. You can't possibly be so. So if you develop a reputation for certain types of methodology, that's good. You build, harness, develop that kind of expertise. But you won't develop an expertise in everything. And I think that nursing and the other allied health professions have tried to be good at everything, truth to tell. But I don't think you can do it. I think you have to know what you're good at, stick to it, and talk about it as sufficiently as you can. So I mean that when I talk about modest ambition, that's particularly what I mean. I think there are some strategic comparisons between the UK and Australia, and just one or two things just to talk about in relationship to that. And often this stuff, I think as David described, it's a matter of context, politics and timing sometimes. We've had the nervous breakdown about Big Pharma saying, if you don't give us open access and easy access and permissions to do our business, we'll take it to India. We've been through all that, and they don't usually do it, truth to tell. But we have responded to it, and I think certainly one of our comparator activities has been a report produced in 2006, which is about best research for best health, is what we call it. It set the tone for the landscape which David has described earlier. And it bears some comparison, I think, to McEwan as well. I don't have to go through these again because you've done it so well already. So that's the list. I mean, those are the headers that you offered to us. These are ours. We want it to be one of the best in the world. And we're all right. You saw the data that David presented. I mean, we sit fairly well in that kind of thing, but you can lose that reputation quite quickly. So how do you sustain your place in that international community? And part of our best research for best health was to seek to do that. How do you attract, develop and retain the best research professionals to do that people-based research? The landscape changes quite significantly internationally. When I was a Pro-Vice-Chancellor at Manchester, we had 2 posts available in the mathematics department, and they were both Russians who got them. And they went from Russia to the USA to Manchester. They did a well-recognized circuit around the system, and you'll find that in a lot of discipline subjects that people plot pathways internationally now to attract and be the best of the best. Not sure it's true in our own professions thus far, but there are some internationalists that you'll find working across our countries. We wanted to commission research focused on improvements in health and social care, and more of that anon. Managing our knowledge resources better, in more commonly and better. We were little empire states in the United Kingdom. Manchester would compete with Liverpool and Birmingham and London to get whatever they could and get one over on their neighbours. You can no longer do that in that kind of way now. You have to look at how you can best combine effort, I think. So you will find national collaborations across subject entities now in a way which we never had before. And because money was beginning to be tight and we were going to see disinvestment in health research to some extent, we had to be good custodians of public money and public good, and for the public good. And that's one of the overriding kind of echoes that you'll see in our research agendas now. So what happened next with us then? If that's 6 years ago or so, I'm going to offer you 3 examples which happened, which, as a consequence really of that, we put a really determined effort into developing clinical academic careers. Now in medicine it's interesting. You can be a clinician, you can sustain your clinical competence and be a researcher because it's set up that way. There's a long tradition of that. My generation of researchers often left the clinical environment to train as researchers and never went back. They stayed in a university setting, to some extent divorced from the clinical environment. And I know you have joint appointment professors between the clinical and the academic environment. But it's not common globally. It's certainly not in nursing and the other health professions. We are seeing a change in that. We are seeing more of those kinds of people emerge. So the relevance of our research in nursing wasn't always on the button. Ideas dreamed up in ivory towers often, rather than of direct relevance to practice enhancement and development and patient good. It is different now. So there was a report in the UK called the Walport Report, and that was to attend to the needs of developing clinical academic medicine and life scientists in the broad sense, biological scientists, and developed their research careers in a significant and purposeful way from graduation onwards. He didn't wait until they were inspired to be researchers. I've met and talked to Mark Walport, and he said, we only take the best of the best. And he's absolutely proud of taking the best of the best. This is not for everybody, he would say. And that's true, it isn't for everybody. So we subsequently followed that with what's now shorthandedly called the Finch Report for Nurses and the Health Professions. And it was an identical kind of activity to say, how might you get hold of nurses and other and allied health professions at graduation, take your first-class graduates, lay a hand on them, and guide them into a research career that would then make them, in due course, eligible for the kinds of grant opportunities that David was describing earlier. They will be as good as. And there are some now in the UK who do get, small in number, but significant grant through our medical research councils. I was part author of the Finch Report, and I'll talk about it in a little later on in a further slide, but just to show how we've taken through people from graduation and onwards. Interestingly, a global issue, clearly, the simplification of ethical approvals. Labyrinthine, unnecessary ethical approval systems were in place for us. And it was all supposedly in the name of patient good, but not really. It was all a wonderful exercise in bureaucracy. So we had to slim all of that down without damaging what patients and families had as of right, that necessary ethical oversight. And that's been quite difficult to do, but I think we've gone quite a long way down that path. And there's been an interesting debate in the UK about, on the one hand, if there's a yin and yang of it, post-genomic research, white ratists, and then innovation science. An interesting debate on then is there something called innovation science that should be funded in the same way as genomic and post-genomic research? And the argument is, yes, you should have that equal opportunity now. So, as I left England, they were just announcing the creation of a committee to consider new and emerging research ideas and their possible potential, which has been set up by government to catch ideas early, invest in them, where there's seen to be promising research activity. But at the same time, we've got another report which is called Innovation, Health and Wealth. My sense is that it's driven by a need for savings rather than by a need to develop best service. We've got to take out of our health sector billions of pounds of savings because there's no money anymore. We're even poorer than you. And you may think you're poor, but there is no money going now into our system in a scale that we've seen over the last 12 years. So we have to take things out. So you have to innovate service using less resource and do things differently for less money. So we used to have programs, for example, our productive ward program was called Releasing Time to Care. That was the subtext. It's now productive ward, releasing money to put in somewhere else is probably the subtext with it now. So we've moved from the best of intentions to the absolute need to save money. There is no money in our system for growth now. Just a little thing, I guess, about the need for excellent and top-ranked activity. Hot centres, and there are, you could list them here. You have your kind of Russell Group equivalent of what we would call the top 8 or so in the United Kingdom here. They get everything, they always get everything, and they put themselves in a place to get whatever's coming just around the corner. They're really good at that. They're set up to do that. My argument would be that here, and places like here, have an opportunity to create a new agenda. Places where they will not go. Places where I was at Manchester would not necessarily have that expertise to go into those kind of areas where you have that expertise, I think. Working with people who use services, perhaps. Innovation and creation in different areas than they themselves might do. The sense is that we're just about to embark on a new research assessment exercise, 2012 to 2014, and they've changed the rules a bit, which is quite interesting. And more of that in a moment. So we're now in the midst of that, and there's an interesting additional thing and it looks like that. So your university, let's say it's here, will be assessed on its research outputs, 65%, impact, 20%, and the research environment, 15%. Now, I know you're good at research environment because you've got this week. You look after your students, you listen to them, you work with their projects, you've got good supervision and oversight, I know, because I've talked to Daniel and others on many occasions about that. So this is a good place for that. So your research environment is pretty good. I've no sense of your research output, I don't know, so I can't offer a judgment on that. And I can't talk about your impact either. But we've been trying to tease out then, what does impact look like? So for this research assessment exercise, we've seen the interesting emergence of a case study in the UK. And a case study seeks to do this. What was your research? How impactful was it? How did it lead to the impact? Who benefited and what changed? What's the evidence of that impact? And how can you verify that those claims are true? Now, if I was starting again, I wouldn't know if I was 25 again. If I was doing it again, for example, the work that was referred to, our work with people with schizophrenia, we know it had a really dramatic impact, not only on the provision of services and people who use services, but the way that people worked. And those were the kinds of papers we wrote. And I could pull into the room several mental health acute services who would say, yes, the Thorn program, that was the shorthand for that program, changed the way we delivered services. Too late now. I can't go back with that program. But that's what people will look for. Okay, so if you're doing something, several of the projects I've seen, which we'll hear about in the course of the week, will really have an impact on how people use and think about services. If you don't have that here now, that 20%, which is this, articulated in this way, you will soon. Okay, so the white ratists are a bit anxious about all this. How might you take account of that in terms of genomic, post-genomic research? You can do it, but you could do this quite easily, I think, in the context of the kinds of work you do. So one can feel the rules changing a little bit, and you see it coming in the States and their research assessments too, I think, to some extent. Really quite interesting. So I asked the question, can new and emerging centres succeed and what remains to be done? Well, yes, I think you can. You can start a different kind of agenda then. And I know the themes in your faculty here, I've seen them, and they lend themselves to this kind of opportunity very strongly, I think. They're a bit, the Dean's not here, is she? No. But this is being recorded. But they are wide, I think. Perhaps you need to focus quite particularly in those wide subject entities and say where your true and absolute expertise lies. Perhaps a little more. And there are two things to do. I guess you're going to be quite good at this too. How do you get your service providers on side then? That's where your alliances, people who offer service, hospitals, units, community services, can be your best friends. They can agitate for money, for research, for support in a way that others can't. So if you have a mission, that should certainly be one of them. I know you work productively with them. I've heard several people talk about it. But then how does that show itself? Okay, a strong alliance is really quite powerful in this context. But equally, how do you engage people who use services? And do you do it other than a gesture? Do you do it in a purposeful and meaningful way? I, until 2 years ago, chaired something called the Academy of Nursing and Midwifery and Health Visiting Research. And we thought we should take a bold step and say to consumer groups in the UK, if I gave you a good researcher, Daniel, you can have him for 2 years, he's really good, what do you want him to do then? So I can give you an expert researcher. What would you, as a user of service, as a family, of a relative who you serve, what would you want that expert researcher to look at? And I went to senior nurses, leading hospitals, and said, if I gave you Daniel, what would you want him to research then? And the lists were utterly different. Absolutely and utterly different. So if you give people who use services a chance to list their own agenda and say, I want these top 5 things, they will tell you. If you go to them with a project and say, will you join in my project? They say, yes, of course, but it's not theirs. They're and they're always an afterthought, really. As nice as you might be and as honourable as you might be, they're always an afterthought. So there's a mission here which might say, if you know who all the health consumer organisations are in this geography, go and talk to them and create a live agenda which says, this university listens to people who use services and these are the 10 things they want. And we have the necessary research expertise to help you. It's a very powerful alliance. We've worked with people I'm a trustee of something called Dementia UK, which doesn't work with people with dementia, but works with their carers, because they are often inexpert, scared, don't have to hand what they think is good ways of working with their loved ones. And often all they need is reassurance, but they will give you a huge amount of intelligence about how those services respond to their loved one and the needs they have. So a very powerful alliance. I think there's a lot of certain mileage to be had there. So what do we talk about when we talk about research in the health sector? Well, genomic and post-genomic research, a thing of my lifetime, which I almost just about understand. But it's over the horizon for me. It's not something I shall ever be part of, but I love it. It's so exciting. The potential is just so fantastic. So I won't be there doing any of that, okay? I won't be growing ears on a mouse's back. But people will do that, and the consequences of them doing that will bear down on me as a nurse and how I deliver service. So let's say, I think, David, you referred to diabetes care, for example, as being a priority. So what if we discover a cure for diabetes then? What does that do to nurses who work with people with diabetes? We've got a workforce of 20,000 diabetes nurse specialists in the UK. Okay, so where do they go? Just go home? What do you do with them? So although I won't be involved in that, the systemic effects of that will bear down on me and my colleagues and what they will do. Okay, I'm wildly speculating here, but we've seen, in my own professional lifetime, I've seen huge change in the way that people are cared for. I used to look after ladies of 65 with a fractured femur, and 25% of them died because of a chest infection. 25%. And I used to look after men with hernia belts, supporting their hernias. You don't see any of that now. None of that now. It's in one career lifetime. In another career lifetime, we're going to see significant impact from all of that in a way we can only just begin to imagine. RCTs, product devices, systems testing, all of that kind of thing. In April, in London, we shall have something called Expo 2013, which is a fantastic exhibition of exciting and scary health inventions using microtechnology and all kinds of things, which are just incredible to the eye, just to see laser surgery at one end, the thinking house at the other, which will tell my district nurse how many times I've been to the toilet, although she lives 15 miles away, because it's wired up to her iPhone, and she knows. So all that kind of stuff is really quite interesting. And then there's this thing that I mentioned before, improvement science. And can I just ask, people have heard of the IHI in the United States, Don Berwick, and all of that? He's written a really handsome paper on improvement science, which argues it should take its place alongside all of those other things. It has an honourable place. He suggests that the research methods involved in improvement science are as good as anywhere else. So, for example, my own organisation, with all that money that we had, developed two interesting programs, our Productive Ward program and something called the 15-Step program. The Productive Ward program looks at eradicating things like medication errors, falls in hospital, a whole list of things that it's quite possible to eradicate if you organise your ward differently. Well, that's not the stuff that David was talking about, but it directly impacts and affects the lives of people who use those services. 10% of people, is it, or thereabouts, will have a fall while they're in hospital during inpatient care. No matter how hard we try, they will do that. But you can eradicate it if you go through your productive ward or your productive series in some organized and systematic way. 15-step program is another interesting example, which says that when I walk on a ward, came from a mum of a girl who was in a young person's unit, and she said, I can tell within 15 steps of going on that ward whether it's any good or not, whether it's well organized, whether it's safe, whether people acknowledge me as I walk through the door, those kinds of things. And you think, well, how do you measure that? How do you change that? How do you analyze that? The 15-step program says, well, you can. It is quite possible to do that. So if you take a list of things that you want to test and measure, ward atmosphere, do people welcome you? Is it clean? Does it smell? Are people able to recognize you as you walk through the door? And we have our student nurses, plus a person who uses services, plus one of our executive managers to go onto a ward and say, this is what it feels like. It's a simple 15-step program. And it's exactly the same program is being rolled out in community nursing too. A bit difficult, a little bit different, but you can do that. And you can enhance services and you can save money out of those services by doing that. So improvement science is, I think, certainly something you might want to consider. It's getting a reputation for sound science. It uses methodologies that you'll be familiar with as part of changing systems and structures. It's not a science in its own right, but it takes advantage of them. And systemic thinking has to be a part of that everyday practice. If you do something to one part of a system, other bits will react. So if I stop doing something as a nurse because other people start doing that stuff, or if somebody as a doctor stops doing some stuff and I as a nurse pick that up, the systemic effects are huge. So everything, the argument goes, should be systemically thought through. And we think there's one challenge in my lifetime left. There's many more. And it's this. It's large. I'll go to this logo in a moment. It's large-scale change. Scale at change. Change at scale. If I can do some research which says I can work with people with schizophrenia in the following ways and they will be better as a consequence, why doesn't everybody do it then? Why doesn't the system take on board all this good research that you're going to talk about this week? How do you encourage and enhance change at scale? Well, some very brave souls have decided that the National Health Service in the UK should think about large-scale change. And they work through this kind of cycle of activities that you see here: leading change, spreading innovation, improvement methodology, rigorous delivery, transparent measurement, systems drivers, and engaging to mobilize. Those are the things they say are the key to taking my piece of research, which we know will have a dramatic impact. I've proved it through my research, translating it out into that system at large. So you will see people in the UK talk about large-scale change, and even the Chief Executive of our National Health Service uses it every other week now. Don't think he understands it, but he talks about it. But that in itself is important, you know, getting that single message on board. So why would you want to consider being part of a clinical academic career? And we were quite exercised in the UK by saying, well, if we want to draw people into these opportunities, do you wait till they're 35 like me and then you start your PhD? Got to get some clinical practice first, you can't possibly do research yet. Or do you get them as they graduate? And there is a momentum, I think, a change which says you should get them young where you can. Don't deny people the opportunity to enter research later in their careers. You should never do that. But you need to start young, a bit like medicine does. And I know this is a slightly difficult to see diagram, but it really starts here in graduation and graduating from practice. So we know now that our nurses will have been exposed to research methods in their undergraduate programs, just as they are here. They will have a basic understanding of that. But the ambition is to build through a master's doctors, postdoc, and senior clinical academic scholarship opportunity now, so that they are sufficiently good to pick up the kind of grants that David described before, that grant opportunity. We've got, I think, half a dozen nurses in the UK, nurses and midwives, who have MRC grants, but they're small in number. But they are as good as anybody else, given that career opportunity. And the people who are given the grants, which I think we kind of reiterated at the end of David's session, are doctors. Okay? Doctors control that stuff, live with it. That's how it is. They understand that pathway. They understand all of that stuff. This is a language they understand. So they're quite prepared then to invest in that kind of emerging scientists who will come out at a postdoc level into senior clinical academic opportunities. So we've sort of cracked it. Well, we thought we had. The scholarship opportunities started 5 years ago. The physiotherapists are good at getting these scholarship opportunities. Occupational therapists, psychologists, midwives, sort of all right. Nurses, not very good at all. No courage, won't apply, or put in lousy applications. It's been very depressing, I have to say. So the opportunities are there. Nurses are missing out for some reason we don't quite understand as yet. I don't think they're just sufficiently well schooled in putting together powerful submissions to get those grant opportunities yet. But it's something that we're working on. So we have the architecture. I think it's really quite important to have that architecture. We'll work on the difficulties a little bit later on. Equally important has been the development of mentorship, so that people working their way through that kind of career opportunity need mentors like you, some of you who've done it all. You know how to lay a hand on a grant. You know how to open a door to an opportunity. You know where to take somebody for tea so that they meet the right kind of person. Medicine does that all the time. I'm a fellow of the Academy of Medical Sciences. And they do that all the time. They have dinners. They have opportunities to take emerging young researchers and introduce them to the greybeards who've been at it a long time and will guide them through those barriers and opportunities. They see that as part of their duty. I'm not sure, certainly in my own profession, in nursing, we're very good at that. Quite good at punishing people sometimes, but we're not very good at pulling people through those barriers sometimes. That kind of architecture has been really quite important to us, however. So if you look at how do you, we said before, we by and large got research methods embedded into undergraduate and postgraduate curricula in a fairly substantive way now. We kind of go through it a lot. It's a kind of process, a rite of passage. But are there other things we ought to be exposing our students to that would get them ready for that other landscape? Well, as I say there, research method modules are pretty well established now. But could you make space in a crowded curriculum to include innovation and service improvement skills then? So a curriculum are always full, we all know that, but probably 10% of it is rubbish. You could get rid of some of it, always. Old-fashioned, unnecessary, inappropriate. If you're really crude and rude about your own curriculum and you look at it in detail, there is some stuff you can lose. The NHS Institute took university partners and said, we'll give you some money if you look at your curriculum and you offer a module that includes innovation and service improvement skills as part of that. And the ambition was to develop health and social care students who are curious about how they could improve their service and are receptive to different ideas and able to bring about the necessary change by applying a variety of tools and techniques in the context they find themselves. There was a purpose to this, a manifold purpose to this. We wanted improvers and service change agents, but employers were saying to us, we don't want the students who graduate, they just know you. We want them to hit the ground running. We want them to be understanding, full of skill, know how to change our services, offer different ways of working, and you don't do that for us. So we said, okay, well, we'll help the universities perhaps to do that. So we invited 4 universities in 2006-07 about 350 students in those 4 universities, and about 8 clinical disciplines: medicine, nursing, radiography, physio, do the 8. We increased it in 2007-8, and 9 and 10. So there are, 97 universities in the United Kingdom. We now think we've got them all. And by and large, all of them are offering a module in service improvement and change and innovation. I don't really see how it can go beyond 23 different disciplines. I've run out of different disciplines, but there are lots in health scientists and so on that you'll find for us. But we reckon that we've touched about 10,000 students by 2009-10, and we're doing a final evaluation phase now of what does all this mean then? What advantage do we gain from exposing students to that stuff? Employers love it. Employers can't wait to take students from these universities where they've been exposed to that kind of exercise, because not only do they understand the theory behind service improvement, they do an active live project in a clinical environment while they're on placement. So they'll do that as well. If we were starting again here, I would have had a kind of first episode which has said, we have to teach the teachers how to do this better. So you can teach students, but the teachers themselves needed a bit of reconstituting as well. But it's been remarkably successful. And it's as wildly popular in medicine as it is in nursing, as it is in several other disciplines. Okay, so if you're going to be a centre of excellence, how do you get that reputation? How do you keep it? Well, you do a lot of this. From what I can see, you do that stuff. You have workshops. There's a week's worth of this going on throughout this week. You're in that place where your research environment is being built and established here. You publish, you do reports, and you respond to stuff, because I've seen some of the responses. So you are a known entity. You have that kind of reputation, and that's quite important to build on. Oh, Canberra does, you know, to be known for that kind of stuff is really quite important. It's probably the case that you have the capacity here to undertake and be aware of translational opportunities. David made the point himself that we may not be in that white rat end, but I bet you're in that end, where you can take existing known research, which says working with people who use services, taking existing research outputs and using them to best advantage. You have those kinds of contacts to do that kind of research. This is not a disreputable reputation to have. Clinical services love it to bits. The fact that you know that stuff and can do it, but to enhance it, make it writ large. And then building on strengths combined with discrete and easily identifiable expertise. Your faculty plan, I've seen your faculty plan, I know what the themes are. They're a bit wide yet. If I look at the spaces in between, help me with this one, what's the spaces in between services? Anyway, but what does that mean then? You know, it's still a bit wide. Is it working with people who use services? Is it around particularities to do with midwifery? You know, where does all that sit then? To refine the language of that is really quite important, I think. But it's a good start. The faculty plan is a really good start. I think it sets the sense of direction and purpose. So I would say, be not of despair. I think you can create, fashion an opportunity which is part of David's landscape, fits well with it in that kind of jigsaw. You might want to retitle some of the things you do that people would recognize in a different kind of way. So I could never kind of understand what was meant by translational research when I worked in a university, because we didn't do that. We just did the research, and other people did translational work. But you're in that place. You could translate stuff which is done elsewhere. There's nothing wrong with that. It's a discrete skill in its own right. You might want to take advantage of improvement science, because I know there are centres in Australia who buy our stuff from the NHS Institute. They buy, at great expense, our programmes on the productive ward or the productive operating theatre. And it will grow and develop its own expertise here. That's a good place to be, I think, at the moment, to be part of that landscape. We have productive ward in mental health, which is a little bit different to the other ones, but it's that kind of improvement science, developmental work, which I think really has a place for you here. And I've worked in both settings. I've been in a Russell Group university, anxiously awaiting outputs and grant, being measured from head to foot for my research competence. And I've worked in other developmental kinds of universities. Both are satisfying. Both carry their own rewards, and both, I think, have their own techniques and particularities, skills. And I think you have some of that here that you could build on quite easily. So be part of David's landscape, but understand where you are in that and where the resource might come from. Okay, thank you.